The market for medical devices and mobile health apps in the developing world is $90 billion. On this stage last year, we had a wonderful speaker, and I asked the question of him what their plans were for selling into the developing world. And his comment was, well, we're just a small company just starting up. We can't afford to give our products away. And I said, well, I hope we can talk after this presentation is over, because that's a misconception that many people have. 3 billion people essentially go without care, have no access to care. That's a pretty big underserved market. And despite our best intentions, up to 70% of the medical devices in the developing world at any given time don't work in the developing world. So there's lots of reasons for this: power, water, parts, supplies, training. But a lot of it is that these devices were designed for first world markets, and they were never designed to be used in the context in which they're being asked to be used now. So this is either a chronic disaster or what an optimist like me might call an untapped opportunity. So whatever misconceptions or preconceptions I may have had about what it takes to deliver affordable care in very low resource settings were blown when in 1997 I was privileged to fly into a famous temple town in South India called Madurai. I describe it as a village of 1.2 million people. And probably half the people who come to Madurai come to see these remarkable temples. The other half come to visit an institution called Aravind Eye Hospital, which was founded by Dr. Venkataswamy, popularly known now throughout the world as Dr. V. And Dr. V taught me everything that I needed to know about global health to commit the rest of my career and my life to trying to make a difference. So one of the remarkable things about Aravind, just very quickly, a lot of you may know about this organization or have heard about it, read the famous case studies from Harvard and elsewhere. Dr. V dedicated his life to, from the time of his retirement at age 58, to eradicating needless blindness. And his one principle that was never to be toyed with was that anyone who came, regardless of their ability to pay, would be treated. And they would be treated in exactly the same way as anyone who paid. And so most people thought he was nuts. And by the time I met him, almost 20 years later, they had done 20 million eye surgeries. So Aravind has become famous for what's now called the upside-down business model. Service for all, designed for dignity, high quality is free, broaden the pie, own the barriers. And the most surprising to me was that his most respected business model, mind you, this is a lifelong vegetarian, a devout Hindu. There are sacred cows wandering down in the street, and he's extolling the virtues of McDonald's. Why? Because you can count on getting replicable, high quality from his perspective. He figured that people who ate this must keep eating them because they were selling a lot of them, no matter where you were in the world. And he thought, if we can do as well as McDonald's has done with eye care, we are going to prevent a lot of blindness and bring sight back to many, many people whose lives, by the way, are absolutely destroyed, not just individually, but in a whole community. To have one blind person who may be the only breadwinner in the family, who may live, I saw many of these people up in Nepal in the Himalayas, one false step and that's it. So McDonald's it was. Be self-reliant, and most surprisingly for many people, train your competition. So because I had not been trained in any kind of pessimistic view of how things could not be done, I was lucky to be the consultant to the senior leadership team at Aravind for a year, and they really persuaded me that this was something that could be transferred. This model, in many ways, could be transferred around the world. So one of the spin-offs from Aravind's commitment was an IOL factory called Orolab. And in the early 90s, they were facing a problem with the 30% of the patients were given care for free, but the only way they could be equipped after their cataract surgery was with these Coke bottle bottom glasses. And the cost of an intraocular lens at that time, made by the only manufacturers in the world, which were in the West, was $150 a lens. And so a man who worked for the Seva Foundation at that time, my friend David Green, went to all of these manufacturers with a proposal. He said, if you come to India to build a manufacturing plant, we will provide the land, we will build the building, we will hire and train the staff, and we'd love to be partners with you just for the technology, for your knowledge of how to build a really high-quality intraocular lens. Oh, and by the way, we have a built-in marketplace because we are the highest volume purveyor of cataract surgeries in the world. And he got turned down everywhere he went. There was not any interest at all. So David, being someone who does not take no for an answer, decided that he would look for someone who had that expertise from within those companies, who was ready to make a change from the corporate world. And so he basically poached someone who was happy to leave, and he hired a very young industrial designer, and they raised $280,000. They made a new intraocular lens, they built the building, they trained the staff, and Orolab is now owns 90% of the developing world market for intraocular lenses. Now you understand this was a great business decision. They are also exporting training of surgeons, training of administrative staff, training of repair technicians all around the world. So they are following what Aravind has been doing all these decades with the capacity to actually fulfill the promise of what all that training provided. The other thing that's important to know is that the price of an Orolab lens, which is the same quality as any first world lens, is not $150, not $75, but $2. And I had a conversation with my old friend Bala, who is the head of Orolab, a few weeks ago. And frankly, it was a little bit of a heartbreaking conversation. I wasn't sure that I would share it with you, but I decided I would. I said to him, I bet all of those companies that turned you down back in the early 90s feel like they really made a mistake now. He said, well, I wish that were the case, but let me tell you what's happened. If someone in India who has means goes to their ophthalmologist, who may well have been trained at Aravind, since most of the ophthalmologists in the country have been, they will get a choice when they have their cataract surgery if they would like to have an India-made lens or an American-made lens. And they will be given the price differential, and most of them will choose an American-made lens. However, what the surgeon implants is an oral lab lens that was shipped to the United States, repackaged, and shipped back. And I tell you this story, so it's a heartbreaking story, but it's an important story for those of us who are working in this space, because I had a conversation just yesterday in this downstairs in the restaurant with a man who has built a very successful chain of primary care health clinics for women and children in Kenya called CFW Shops. And he said to me, you have to follow the money. So it's an important key for all of us not to be beaten down by that, but actually to learn from that. Doctors in the developing world are often very stretched financially. They do not make the kind of money in their countries that doctors make here, or used to make here. So just something to pay attention to. All right, so I said I was the optimist, but so there are many, many other devices like the oral lab lenses. By the way, they have expanded to 60 products, including all the ophthalmic products, sutures, et cetera. There are many, many frugal innovations that have been coming out in the last 10 years or so. They're very good ideas, many of them, and many of them fail because they cannot scale. It's not because they don't work in the developing world, it's because the people who are engineering them are thinking about the engineering aspects, but not thinking about the adoption aspects, not thinking about the market aspects. So the solar suitcase, Laura Stachel, an OBGYN from Oakland, a client of mine, took her solar suitcase, I won't tell you the whole story, it's a long story, to a hospital in northern Nigeria where the maternal mortality rate was 70%. So this is just unimaginable for those of us in the West, but a woman in the developing world does not go to deliver her baby at a hospital or a clinic unless she is in trouble. By the time she's able to acquire transportation and get to wherever this clinic may be relative to her village, she is often in very serious distress. So if you get to the clinic in the middle of the night and there's no doctor, there's certainly no power, maybe they've run out of kerosene, maybe they have a quarter of a candle left, maybe not, but they have no cold stored blood, they have no way to sterilize any of the equipment, they have no headlamps or anything to be able to see what's going on with the patient, and many of them die. And so as a result of this, she and her husband, who's a solar engineer, put together something that's now called the solar suitcase. And this number, this slide was from a year ago. They had 160. They've been supported very strongly by the MacArthur Foundation. They just sent 1,000 of them to the Philippines. So, but the need in the world just for maternal health clinics is something like 300,000. And so they're serving, a few percentage points of what's needed. So there's many, many other innovations like this, as I mentioned, and price has been the weapon in many cases to look at not just how do we make it cheaper, but most important, how do we make it functional in settings that are not like ours, that we have to absolutely think differently, and all of these do. Incubator for infants, a typical Western device, $20,000, requires continuous power. An alternative device, $200, can serve over 20 million people. Prosthetic knees, $20 versus $8,000. By the way, that comes from a company, a not-for-profit called DREV, which was born out of Paul Pollack. Mal Warwick is a good friend of mine, and I also urge you to take a look at their book, Business Solutions for Poverty Alleviation. So the prosthetic knee that they make is a great knee for $20, and they are distributing them now widely throughout the world. So there's no question that there's actually a market for this. So we're going to talk about that more through the panel. So some of the challenges I just want to mention before we begin the rest of the discussion, and we're going to invite you to talk with us as well, is we have to start hacking beyond the how of the device to the how of the distribution. And that's frankly what my organization, BioMedLink, is really designed to do. And we can talk about that more if it's of interest. I have recently become involved in a project called Clinic 3.0, which is focused on the disconnect between the development of rapid diagnostic, point-of-care diagnostic devices and how do you get all that data that in a meaningful way to all the different stakeholders who need it for different reasons. So we have in this country many, many clinicians who have no way to get access to the data from the rapid point-of-care device to the patient before the patient leaves the clinic. And so much less in the developing world, but the problems here are very much the same. If you have a patient who had a hard time getting to the clinic, whether it's a Medicaid patient or whether it's a minor in Latin America who may have traveled a day, took off a day from work to come and get a diagnostic test, just assume that it's affordable. That's fine. But if you don't give a result while they're still in the clinic, they may not come back. And so we have a real responsibility to not just focus on looking at how cool a device can we make that's capable of doing something when we haven't created the system, the end-to-end system within which that device can actually have meaningful use. So you want the clinician to get the information, you want the patient to get the information, you want it to go directly to the EMR, regardless of what brand software you're using. You want to be able to get it, in many places, very importantly, to the surveillance bodies. Because how else can we track what might be turning out to be an epidemic? How else can we track what we need to do? And another big conundrum that many of us are facing is that the capacity of diagnostics is outpacing the capacity of therapeutics to actually be of use. So I mentioned that I had spoken with the founder of the Health Store Foundation and CFW Shop, Scott Hillstrom, the other day. And in the clinics that he's helping launch, that he has launched in Kenya, they're not interested in diagnostics for things where there's no capacity to actually provide therapeutics. So to give a referral to a woman who looks like she has high susceptibility for cervical cancer makes absolutely no sense, because many of those patients have no capacity to get treated for that. So until we can do telesurgery, telemedicine is terrific, but telesurgery is still kind of on the far edges of our capacity, even when we talk about exponential medicine. So one of the things that we need to think about is how can we really make a meaningful difference now and move people towards those aspirational kinds of possibilities through our joining them and collaborating with them and partnering with them in moving forward. So I'm going to invite my beloved colleague, Alberto Rodriguez-Navarro. And Alberto and I met, about 2 years ago at an entrepreneur's boot camp. And we became famous friends. And he's a surgeon, Chilean surgeon. He's now shifted hats to being a medical device innovator. So he's going to spend some time talking with you about that particular evolution.
I'm coming from Chile. I am a minimally invasive surgeon from there. And I don't know, If anybody has been there, I invite you to go there. It's a very fascinating country. We have wine, we have a lot of things. And I worked for 10 years as a minimally invasive surgeon in one of the poorest hospitals in Santiago. Santiago is a big city. It's 8 million people. And this hospital is in the periphery, in the side area of Santiago, where the average income is around like $3 to $4 per day per person. It's very, very poor. It's one of the poorest areas. And we have a population of around like 400,000 people to attend. So it's a big issue. So I was in charge of the OR, the administration of the OR. We have around like 1,000 patients waiting for gallbladder surgery. And the only option that we have in order for give them treatment was doing in an ambulatory setting. The problem was that we didn't have so many beds. So we have to make the surgery in the morning and discharge the patients in the night. And the big problem that we're facing was pain. The patients, like we discharged, I don't know, 6, 7 p.m. in the evening. They arrive to their houses. They live in this poor area that they can't return to the emergency room. So most of the patients just cope with the pain. Nobody died. I mean, we have very good results. However, there was a complaint there. And if you think about it, I did like, I don't know, like 5 years pain research. And if you think about it in surgery, the main cause of the pain are the incisions that you make on the surgery. That's the main, it's like wide accepted that the incisional pain is the one who controls like the pain after the procedure. So if you think about like the evolution of surgery, we begin thinking how we can improve this. And if you see like the transition from like open big incisions like of the old surgery that evolved to multi-port laparoscopic surgery, that's the standard today, the main thing is that you reduce the number on the size of incisions. So we figured out that if moving forward and to keep reducing the number of incisions and the size, that will be better and we can control our patients. The main problem when you move from like multi-port to reduced port is that you begin like having trouble with the instruments because you have to put multiple instruments through just one incision, so it's difficult, you have clashing, you don't see well, so you can increase the risk of the procedure. So that's why there's no way of doing like safely. There's some issues with the devices in the market. There have some attempts to address these things. You have like curved instruments, you have like some internal hooks, but none of them is really good for solving the problem. They are difficult to use, so there's not a good solution for that problem. Even the robot right now is trying to address these things, like going through just one port, but there's no a good way and a cheap way of doing it. So we begin thinking what we can do in this environment that we don't have too much resources, and that's one of the big things and the big like message that I can give it to you is like look the emerging market as opportunities to find creative solutions in order to evolve and do the things better. So well, my family have been very lucky. My family is only engineers. From the miner side, Chile, the principal product is copper, and we have very good like engineers. And my family is only engineers. My father is a mechanical engineer, and my uncle is like electronic engineer. So we have like family talks. It's mainly about engineers. So we talk about it. And when I was a kid, I have a tank of turtles that for cleaning these tanks, you have some system with magnets that in order for not to change the water, you put a magnet inside of the tank, and with external magnet, you mobilize it and you clean the tank. So in this poor hospital, one of the poorest hospitals in Santiago, we developed this concept of trying to do the surgery using magnets. And I realized that in order to keep moving this idea, I had to move to the US. We did the first prototypes there in Chile, and then I moved here. Now we have like a clinical product, and we are now beginning with the FDA process, and we are doing clinical trials in Chile. But the message here is that what we found in like this poor hospital that is a problem for the patients, you can bring it here, construct the device, and it's a device that can have a global like use. So it's a better device. It's another device for surgery that has a lot of like advantages for what we have now. And the idea began in a public hospital in Chile, an emerging market. So well, the message is like, look other countries and the emerging markets as an areas of potential collaboration. There's a great opportunities to do business. There's a lot of opportunity to create value. So it's my idea is like invite you to look the things with other eyes. Thank you.
The information from my colleagues was consistent to what I understand as well. There is a market to be had. There are clever ideas everywhere. And while I won't get too superficial about it, this is not at all surprising. And the opportunity to hold international explorations of such ideas is relatively uncommon. I don't know many, and the ones that I do know are phenomenally expensive. So having an opportunity to get a deliberately expressed innovative view of multinational efforts is uncommon. And please feel free to take great advantage of it. You're not a room full of VCs, but if you were, you could make some money.
So I wanted to ask both of you about your experience working with medical devices designed in and for first world markets in the settings where you've been working. Alberto, you had lots of experiences at the public hospital in particular, I think, that are relevant.
Yeah, I mean, the one that I show is just one of many of the solutions that we thought, because as I told you, when you are in a hospital that don't have too many resources and you have the pressure from the patients, you have to be creative and you have to be efficient. It's like a very, what do you say, like extreme environment in order for to be able to find solutions in all the patients. So yeah, I mean, we have talked that there's a lot of things that others ideas and things that we have done there in the hospital that are very cost efficient and solve the problem of the patients, and that can be explored and that can take up to a company.
So you told me a specific story about otoscopes?
The colonoscope, the colonoscopy.
The 5 scopes that you had and only 4 of them.
Yeah. I mean, also I was chief of the endoscopy unit in the hospital, and we have some problems with the turnaround of the devices because after we did the studies, we have to clean it. So I figured it out that the problem was that the people who take the endoscope to clean it take a long time in order to clean the device. So that was the biggest problem. So we just figured it out to put like a paper with the time that the device was ready after we finished the exam and the time when the device returned clean. So then the people who was working figured it out that there was some like accountability of the time that they take in order to change the device to clean it. So we increased like 40% the number of endoscopies just putting like a paper on the devices. So that's the thing, is like you have to be creative and go there, see which is the problem, analyze it, and try to develop like cost-effective solutions.
So when Alberto first told me this story, he said that when he became the chief of endoscopy, that there were 5 endoscopes in the hospital that was serving 1 million patients.
400,000.
400,000, but it was designed for 100,000. Yeah. And 4 of those 5 endoscopes were not working at the time he took over. And so we explored this a little bit more, and he told me, you know, what the solution was. So I asked him, what would you advise a maker of endoscopes, just as an example, to do in order to be, obviously these were purchased, by the way, these were not donated endoscopes. What could have been different that would have made a difference? And the answer, well, I'll tell the answer, or you want to join in on that? So the answer, anyway, that I took away from this was that the endoscopes could actually have been technologically a little bit simpler. They were not designed for anything like the volume of surgery that they were being used for, because, you know, just like in India, at Aravind, each ophthalmologist does 100 cataract surgeries in the morning. I don't know a single surgeon in the US who has anything like that kind of volume, maybe even, in a year. So, and then the other answer was, the product doesn't have to be cheaper, Terry. It could actually be more expensive, but if it included a warranty, someone who could repair it, better instruction about how we could keep it clean, that would make all the difference in the world. So part of what I want people to walk away with is understanding when we're talking about end-to-end solutions, you're going into a context which does not have the infrastructure. It isn't that medical devices don't break in the US, it's that we have a whole universe of people and services that are already designed to be able to solve those problems for us. You want to add anything to that?
Yeah, what I can suggest and recommend is, like, if you're able to solve a problem in that kind of environment, also you can have a market here and everywhere. I mean, it's like, if you are able to deliver and be creative to solve that kind of problems, besides that you generate a market in that specific country, you can extrapolate and grow.
Yeah, absolutely true. Spare parts are an issue. And I have, for example, a photograph of a set of crates in Qasr Hospital in southern Iraq that when we got there, we asked what it was because it was written in German, and the people in the hospital said, we have no idea. And for 2 years, a CT scanner had been sitting in their hallway. There had been no continuity. There was nobody who read German. It was just poor planning. Even if it had been put together, there was a training component, there was a logistics support component, there was an upgrade component that was missing entirely. We have had USAID, for example, install medical clinics all over Afghanistan. I think the total number of installed medical clinics was 120. Unfortunately, they all were provided with generators for power, and not one had a fuel budget. So that's pretty much that. And by the way, they were all built on kind of Midwestern, Southern standards. Apparently there was a cookie cutter that came out of Alabama or Oklahoma or someplace, and the ones that were in the snowiest areas just collapsed. And incidentally, nobody took note of the GPS coordinates of where those clinics were built, and so forth and so on. These are failures in systems. And the fact that there was no fuel provided for is a serious oversight. And if you just extrapolate that into medical devices, making sure that your devices have as few parts as possible is helpful. If you are willing to provide the 3D renderings and the mechanical drawings of your spare parts requirements, they can now be built with 3D printers anywhere in the world. 3D printers are much more popular in some areas of Europe and South Asia than they are here so far, because we have the manufacturing capacity for high-tech stuff. But if, when things break, they can be replaced on site with materials that you know are commonly available, and you provide the files, it helps everybody. It also makes you look kind of bleeding and spurting edge, and it would be cool of you to do that. It's a serious differentiator in 2014. It won't be in 2018.
I just want to tag on to that by saying that David Green, who I mentioned earlier, who helped develop Oralab, went on to be named a MacArthur Genius winner. And he also did the same thing with hearing aids as he had done with intraocular lenses. And what he did was they used all components that were commonly available in the developing world, none of which had anything to do with hearing. So instead of a $3,700 device, they got it down to $80. And it works well. People can repair it. They can get all the parts they need. They don't have to have a supply chain or a whole extended repair network for that.
Terry, I know there are a few questions, but yeah. I think you have some for the panel. I want to respect both sides.
Let's have people jump in.
Okay.
It'd be great.
Thanks for the talks. Fantastic. Puts things in perspective. Just last week saw a replay of a TED Talk where the story was about, I don't remember the country in Africa, where neonatal incubators were an issue, and while they could be delivered, they would break and not be able to be repaired. And the solution was that they seemed to be able to keep their cars running, and they ended up designing an incubator 100% out of used car parts. Right. The incubation element were actually the headlamps. So I say that to ask this question, and that is, are there firms that are immersing themselves in those cultures to understand what the challenges are and what the repletion options are?
Absolutely. You know, I'm kind of looking across the spectrum, and I would say that many of the examples that I gave here and that you just referred to, I call frugal innovation. And so whether the frugal innovators are located in the Western world, as many are, you know, there are a lot in the Bay Area, you know, these social entrepreneurship, some of them are nonprofits, some of them are for-profits, some of them are hybrid organizations. There's a lot of that happening. The challenge is that most of these innovators don't have the capacity to scale. They don't have the marketing and sales expertise. They don't have the kind of budgets. And so one of my goals really for speaking at this meeting about this topic is that on the other end of the spectrum, well, we have Medtronic, we have GE Global Health, who have both on a corporate level made enormous commitments to the emerging markets. And while much of their effort is now targeted to the top 10% of the emerging markets, which makes a lot of sense. Those are like first world markets that just don't work very well yet. They're also looking, I know from conversations with people inside both organizations, they're looking much farther down the chain, and not necessarily only at the products that they currently are delivering. And so, you know, so then the question is, well, there's a vast middle between these two extremes. And I'm very curious about what people who are operating in, you know, more conventional medical device space than the frugal innovators, but at a smaller scale, think about this, and what are the challenges, the opportunities for you that you're seeing that we might be able to help you address. I know I spoke yesterday with Tom Kramer, who was on one of the panels yesterday afternoon, and I'd love to have Tom share his story. Joe, you have the microphone, but Tom is right in the middle of the room. Is it possible to? And we'll get to Robert Packard momentarily.
You preempted Robert for me.
I'm sorry, I didn't realize until after I'd already started talking that was what was happening.
Yeah, well, so I'm with Kablooey Design. We're a small product development consulting firm, so we do product design and engineering for all different kinds of clients. And so yes, we have worked on projects for customers who are trying to develop products for emerging or underserved markets. Sometimes there are markets here in the US, like the pediatric market. There are certain disease states that are hugely underserved because there just can't be money made in low populations like that. But then other times they are for third world countries. So often, you know, what we have to do is take a team member, of course, and get your development people, your designers, your engineers, get them over there to do research on the ground to find out what the environment's like. And it's really no different for us from a development person standpoint, an engineer or designer. One of the things we always do for any new innovative device we're developing is to understand the environment that it's going to be used in. If it's in a US surgical hospital, what is that surgical room like? Who's going to be using it? Who are the techs, the physician? It's the same principles, just applied to a different area. What is the environment going to be like in Bangalore, where a device is going? what type of facilities, who's going to be administering the use of it, what type of resources they have. It's all that upfront research type study that we have to do to familiarize ourselves with it so we can come back with that information fully loaded and ready to begin to develop ideas that will actually work for the environments they're intended.
Thank you.
If I can make a comment on those who would like funding for their devices, there's a brand new initiative out of USAID called the Global Development Laboratory. The grand opening in New York was about 3 weeks ago. It's actually going to be located in the Reagan Building in DC. It's going to take 1% of USAID's budget, which means it has a fixed roughly $200 million a year available for creative ideas and development around the globe. Some of it is being driven by the missions, the individual USAID missions inside the embassies in various places. There are 12 of those missions that have elected to take part. But if, as the gentleman was just saying, you wish to immerse yourself in the kind of environment that is likely to be a market for you later on, there may be a competitive process that has a very substantial amount of funding behind it open to you, the Global Development Laboratory at USAID. If you want to talk to people who are already immersing themselves in all of this, you can talk to Amy Smith at the D-Lab at MIT. You can talk to Revi Sterling at the Atlas Institute at the University of Colorado in Boulder, and you can talk to anybody at all inside the D-Lab at Stanford.
Thank you, Eric.
Alberto.
About financing, we are totally financed by Chilean money. We have a grant from the Chilean government of around $2 million. And we have also Chilean VCs. So there's opportunities in Brazil, in Chile, in Colombia of finding resources. So if anybody's interested, contact me, I can put in touch.
So this is another good point. We actually know of people who are doing work on products that are destined to launch in India, and they're 100% backed by Indian VCs. What we would encourage everyone to look at is partnerships. How do you partner with folks who really know the culture from the inside? I've spent a lot of time in India, and there is no way in this lifetime, if I spent the whole rest of my life in India, that I would ever, ever, ever presume to understand the culture at the level that someone who grew up there does. So partnership, collaboration is extremely important, and it could be valuable for you in terms of your funding as well.
Wonderful insights by everybody. I really appreciate it. This question is actually directed to the panel, but I'd like to focus it mostly on Eric because it's relevant to his talk. One of the points that you did bring up near the end, and it is a common issue that's going to be in the future, is fresh water supply. It's going to be one of the major crises that's already in effect right now. And I'm wondering, regarding your device for the purification system, some logistics. One, does it have how is it for desalination? And secondly, how cost effective is it to be able to produce these things? You have a working prototype right now, and I'm wondering about that. And if you don't mind, I'd like to, one additional point is, since everybody has traveled extensively, but you in particular, you brought up Tajikistan and part of the parts of former Soviet Central Asia. What are the logistics regarding the Aral Sea crisis, according to what you know, if you could address both of those separately?
Well, you don't go for the trivial ones. Okay, so number one is easy. It does not, repeat, not desalinate. That requires an ion separation, and that just is too energy intensive. On the other hand, our friend Dean Kamen, Daniel knows him very well, I know him less well, has invented the slingshot. The slingshot does 1,000 gallons a day. It's about 2 cents per liter, and it does desalinate. It's being evaluated by Coca-Cola Corporation in Cape Town, South Africa, in something called an eco center, which has compressed natural gas out of one side and water out of the other. There's a similar process in Vietnam. The problem with slingshot, because Dean's an amazing inventor and a creative mind par excellence, business, different. The Segway is brilliant, but not affordable. The slingshot does 1,000 gallons a day and is $100,000. That's a bit much for most environments, most economies. What we're working with at Puralytics, and by the way, I have zero financial stake in that company, none. I am an interested user, and I beat them like dogs for moving their stuff around and getting the research farther along, just because I'm a user, just because I'm buying their stuff, but I pay full price. It's $6,000. 6, not 100. But it doesn't desalinate. It does, however, and I'm just going to push them a little bit here, it does, however, do 3 things very well: biologics, organics, and metals. So it does viruses, bacteria, and protozoa. It does fuels like diesel and gasoline, and pesticides, and fertilizers. And it does heavy metals: arsenic, mercury, lead. So for our purposes, very cleverly done, and we, out of a selection of possibilities, chose them. But again, I have no stake in the matter, and I pay full price. I think they're probably scalable. They have very few moving parts, so they're adapting their technologies to what we need in the field. And there are going to be other better ideas that come along, and I have the loyalties of a cat. So as soon as the next cool thing comes along, I'm going to jump to that. Not very helpful for long-term contracts, but it makes sure that I can come to conferences and talk about good stuff at that moment.
One of the things that BioMedLink is dedicated to doing is really aggregating solutions that are working in different settings and letting the users actually give us feedback about what's working in their setting. So instead of trying to come up with just one solution, I know of at least a dozen at least water solutions off the top of my head that are working in various settings, and so if you want to talk with me about that, you're welcome to.
We have time for this last question.
Okay.
Great, thank you. So one question I wanted to ask is, we're talking about getting medical devices there and getting products there, but a big issue, as we were talking about in Australia, is maintenance, right? You can donate all the equipment you want, but maintaining it can be an issue. One of my colleagues, Tiffany Diaj, is actually working with the Ethiopian Ministry of Health right now. I think she's actually there, about training people to maintain and things of that nature. So I just was curious about your thoughts about that in other markets, and what some strategies might be to train people to maintain the products once they're sent, for those that can't be disposable or single use.
Wonderful. Thank you so much for asking that question. One thing, like sunlight, in many of the places in the developing world, they have no lack of that, which is why the solar suitcase has been a success. There's no lack of workforce. And I really saw at Aravind how they plucked people out of, young people out of villages and trained them to be operating room nurses to do this remarkable conveyor belt kind of surgery with higher, less infection rates by 6 times than in the UK and the US. So you'd never know it by looking at it, but it is possible to do that. I'm actually beginning conversations with folks at UNHCR. We saw a horrible photograph of what one of those refugee camps looked like. UNHCR has actually recently launched an initiative in collaboration with the IKEA Foundation to train refugees in some of these camps where there's very little prospect of them ever getting out, to be able to do customer call centers. And we're very interested in the same thing in terms of tech support. And so I think it's not that there's fixed infrastructure there now. There's vast opportunity that really depends on our willingness and our ingenuity and our collaborative efforts to be able to make these things work. So what I would say is, none of this is a cakewalk. Going and working down at a level 1 clinic in the developing world or a level 0 clinic, but it also is not brain surgery. So I encourage you to really look at how this could serve your bottom lines and serve your missions as humans as well as business people to find a way to bridge that gap.
I think that's
Thank
a great
you.
way for us to conclude. Please help me thank our panel. Terry, Alberto, Eric, for doing such important work. Thank you, everyone.